For the next session, I would like to call upon Dr. Niren Bafsar, Lead Consultant, Cardiac Anesthesia from SIMS Hospital, Ahmedabad, and Dr. Indra Jaikumar, Consultant, Pediatric Intensivist at Apollo Children's Hospital, Chennai.
The session begins with the first lecture on AKI and CRRT on ECMO by Dr. V. Chandrasekaran. Dr. Chandrashekharan is the Director and Clinical Head, Institute of Renal Science and Kidney Transplant, MGM Healthcare, Chennai. And his area of interest is transplant immunology, kidney transplant, pediatric kidney transplant, highly sensitized kidney transplant. Dr. Chandrashekharan.
Good afternoon, and thank you for the invitation. I thank ECMO Society of India and Dr. Suresh Rao. No, I've been invited as a filler. I think I can do justice next few minutes. CRRT is one of my passion. I always believe CRRT is like renal hemodynamics. It's the ultrafiltration and convection, or the physiology of CRRT is akin to renal physiology. Extracorporeal life support is an effective therapy for those patients who are critically ill with cardiogenic shock as well as severely hypoxic lung injury. And critically ill patients on ECMO always have coexistent multi-organ failure, including AKI and fluid overload, both of which influence the final outcome. They are important prognostic factors. And if they develop AKI, the morbidity and mortality is much more higher. And most of these patients, there are different modalities of renal replacement therapy, but most of these patients are too unstable for conventional intermittent hemodialysis, and most of them may require continuous renal replacement therapy. I start with a short case history. A 54-year-old gentleman with a medical history of hypertension, coronary artery disease with status post PCI was transferred from outside hospital for ECMO consideration after being treated for acute respiratory failure in another hospital in ICU. 2 weeks before the admission, he had upper respiratory tract symptoms and was on antibiotic without much improvement. He required non-invasive ventilation. Finally, he required a invasive mechanical ventilation, and subsequently he had worsening hypoxia despite antibiotics, steroids, diuretics to the maximum, prompting transfer for ECMO support. Just before the transfer, he had a CT chest which showed bilateral ground glass opacities. At this time, we as a nephrologist was consulted after ECMO cannulation for oliguric AKI. So he was intubated and mechanically ventilated on VV ECMO with systemic heparinization, on pressor support with noradrenaline with his increasing requirement, and he was on antibiotics with meropenem, vancomycin, and antiviral oseltamivir. He had been anuric for the past 12 hours despite a high diuretic challenge. And cumulatively, the patient had 15 liters of positive fluid balance. He was anemic, WBC was a little bit up, urea was around 120, creatinine at around varying between 2.4 to 2.8, potassium at 4.9, ABG showed metabolic acidosis, hyperlactatemia with mild elevation of ASTs and LLTs with coagulopathy. The patient's sodium at admission was 130, but it is progressively declining to around 120 at the time when we had a look into the patient. So what are the causes of AKI in patient on ECMO? So there are multiple predisposing factors. It could be a pre-treatment patient-related factors, probably related to hypoperfusion, loss of renal autoregulation, that is loss of tubuloglomerular feedback, which is protective, but because of auto-regulation, the tubular glomerular feedback doesn't work. Could be due to hypoxia, or can be increased intrathoracic or intra-abdominal pressure, administration of nephrotoxic drugs, or it can be a part of systemic inflammation. And there are also other ECMO-related factors. Could be hemodynamic factors associated with alterations in the blood flow. It could be hormonal factors, RAS dysregulation, as well as downregulation of atrial natriuretic peptide because the right atrium is almost empty. ECMO-related systemic inflammation as a result of blood shear and stress. It could be due to exposure to artificial membranes, ECMO as well as CRRT membranes, which even though they claim is most biocompatible, some amount of bioincompatibility may persist, and the tubings with blood contact can activate the surface factors. It can be circuit-related factors which can activate the myoglobin, can cause hemolysis, or can activate the coagulation cascade. And there may be other organ crosstalk. Could be a cardiorenal, or there may be lung-kidney interactions, probably as a result of PEEP as well as invasive mechanical ventilation. Apart from this, we also consider CRRT in these patients based on acid-base and electrolyte disturbances. And most important is the fluid overload. When to initiate? So there are a lot of studies from early 2000 to late 2020, but there was no consensus yet reached on when to initiate. Early means what? Whether it is at the time of diagnosis, at the time of initiation of ECMO, or at the time of admission, or at what creatinine, or any other factors. And this Rayfield and Akin stage probably it may represent only a surrogate, it's a surrogate marker of timing. Already the kidney function might have gone down more than 50%. Though there are rationales for early initiation, probably for volume and acid-base optimization, but there are also drawbacks for early initiation. Probably we can consider prolonged initiation, early initiation, prolongation of renal support probably may increase the risk of bleeding and increase the risk of infection, all this and all. So what is the exact, when do you time it? So there are always no standard indications like uremia, fluid overload, acid-base disturbance, dyselectrolemia, but we move from the standard indication. What do you mean by demand capacity concept, right? So it is not the degree of renal failure or the stage of AKI which determines the decision to start CRRT. It's always the demand. What do you mean by the demand? Demand is the ability of, is the burden on the kidney by the disease per se, plus solute overload and volume load, and how much the kidney can handle. So in this situation, we always think of because of burden on the kidney, burden placed on the kidney, what effect does it do to other organ systems? So if by delaying the onset of CRRT, if the decision is going to burden other organ systems, it is always this gap, what do you call demand capacity gap, which determines the initiation of CRRT in these patients. So this is a patient with multi-organ failure, and patient is already in the process of evolving fluid overload. It's more than 15 kgs since the time of admission. Patient had metabolic acidosis, which may prompt CRRT initiation in these patients. And CRRT was initiated in tandem with the ECMO, and so that there is no need for additional access. And beyond these, are there any consideration for these patients when prescribing CRRT? Is there any other considerations? So what are the factors? So one is major factor is the severity of the illness and trajectory, AKI severity, fluid balance, and presence of multiple organ dysfunction, and whether the patient require renal replacement therapy, is it necessary? So is there a likelihood of early recovery in these patients? And you also consider underlying comorbidities impacted by AKI and fluid overload and associated organ dysfunction. Risk of ARRT in the form of vascular access, mostly we do probably in series with ECMO, so very rarely we do parallel intervention, parallel access for CRRT. And you consider the presence or absence of hemodynamic stability in these patients. Other factors, obviously it's more of patient and family wishes and the cost of treatment. So based on this, you choose the modality of treatment, because CRRT with ECMO, it's pose an additional burden of around 80,000 rupees per day. So we all have to consider all these factors before initiation of CRRT in these patients. So what modality you are going to choose? What is the effluent dose? What is the net ultrafiltration you want to achieve? What is the ideal blood flow required for clearance? And whether use anticoagulation or what type of anticoagulation, what is the goal of anticoagulation? All these has to be considered before final prescription. So there is a conceptual differentiation between diffusive and convective clearance. Diffusion is movement of the solute from a region of higher concentration to a region of lower concentration. It's simple. Usually it holds good for small molecular weight solutes. What do you mean by the convection? Convection is called solvent drag or solute drag. That is, when you force the fluid from one side to the other compartment, the force of fluid will drag the solutes, which holds good for patients when the pressure on one side is increased, it pushes the fluids, and when the fluid is filtered, it drags the solute. It's like a waterfall running from high, and on its way it flushes all the rocks and boulders, right? So this is what the principle which is best utilized by continuous renal replacement therapy. It is also utilized in normal dialysis also. So we started with CVV HDF, that is continuous veno-venous hemodiafiltration in these patients with the effluent dose of 30 ml per kg per hour. What is this effluent dose? It's whatever the input into the CRRT circuit. So it consists of different components like pre-blood pump, post-blood pump, that is pre-blood pump dilution fluid, post-blood pump fluid, and dialysate, as well as replacement fluid. So, and then you set the effluent dose and the net ultrafiltration. What do you want to achieve? If you want to achieve the net ultrafiltration of 50, you add that 50 and set the effluent rate. And you adjust the blood flow rate and you decide on anticoagulation based on coagulation profile of these patients. Mostly with, we don't use separate, we use, because patient already on ECMO, most of the patient will be on systemic anticoagulation. We don't use additional anticoagulation in these patients. So what are the, how are you going to connect the circuit with CRRT? So there are three modalities. We can use only the filter. We can use only the filter which is called inline hemofilter into the ECMO circuit. The inflow to the hemofilter probably can arise from, it can be a pre-oxygenator, and the outflow from the filter is returned pre-blood pump. So, and it is probably, you don't need a separate machine. It is cheaper compared to using a CRRT machine in series. But the disadvantage is that there is lack of alarms in this, and we don't have any control over the net ultrafiltration in this. But we can use a stopcock or similar instrument to restrict blood flow in these patients to probably to adjust the ultrafiltration. The ultrafiltration depends upon the blood flow itself here. And usually for dialysis, we just use this modality when the patient needs scuff. Scuff means slow, continuous ultrafiltration, only ultrafiltration. So there is no necessity for solute removal. So it is a slow process, slow, continuous ultrafiltration is a slow process. The fluid removal depends upon the blood flow into the filter circuit. So there is no need for any additional machines. And most commonly, most often we do with CRRT machine combined with ECMO circuit in series. So the inflow could be distal to the blood pump, and the outflow distal to the oxygenator, distal to the blood pump, and the outflow probably we connect to the pre-blood pump. So this achieves optimal blood flow into the circuit, and there is no resistance to outflow. And this again, another modality, the inflow is between the blood pump and the oxygenator, and the outflow is connected to the pre-blood pump. This again, both the inflow and the outflow can be connected to the pre-blood pump circuit. So, but here you have to be careful, because in this situation there is an increased risk of clot or air embolism in the CRRT circuit line. But beyond the centrifugal pump, the ECMO circuit will have a positive pressure, and from negative to positive, and there is no chance of embolization when you connect between the blood pump and the oxygenator. So combining CRRT and ECMO probably avoids additional catheter and associated complications of the catheter insertion when the patient is already on systemic anticoagulation, and it also prevents the risk of infection, because there is another circuit, another connection and disconnection. It is going to run for a long time, long days, and it can pose the increased risk of infection. And again, when you combine both, you always be aware of abnormal pressure in the ECMO circuits. It can be low pressure alarms, can be high pressure alarms, and mostly alarm adjustments frequently required, and it may lead to interruption of the treatment, and we may not be able to achieve the target desired goal. So different types of anticoagulation could be systemic anticoagulation along with ECMO. The target APTT should be around 60 to 80 seconds. That is 1.5 to 2 times the baseline. And sometimes you use systemic anticoagulation plus regional citrate, and RCA is only for CRRT circuit, right? This is to minimize, to increase the lifespan of the CRRT kit, CRRT clotting, and we have to look into the coagulation parameters, adjust the dose of calcium as well as citrate infusion. Sometimes TEG may be utilized to monitor coagulation with ECMO, and sometimes if the patient is severely coagulopathic, most of the time, even in our experience in our hospital, we mostly do without anticoagulation. So complications related to vascular access, bleeding, electrolyte disturbances, hypophosphatemia, hypokalemia, they again pose increased risk for hemolysis and rhabdomyolysis. And you always be careful when you combine both. There is you have to be careful to minimize risk of embolization into the circuit. So what is the outcome? What is the renal recovery in patients with ECMO on CRRT? Very few data, limited data are available. So one retrospective data with 124 patients, of 12 out of 124 received ECMO. These are patients studied retrospectively on CRRT patients, right? Of these, 21 out of these, around 20% of these patients required ECMO. 18 out of 21 required long-term CRRT, more than 6 days, and ECMO duration varied between 1 to 9 days. On multivariate analysis, the predictors of long-duration CRRT were oliguria, mechanical ventilation, and requirement for ECMO. In another study of 48 patients with VV ECMO and CRRT, renal recovery was seen in around more than 2/3 of the patient, 23 out of 30, and 7 out of 30 survivors who got discharged still continue to be on some form of renal replacement therapy. Another study by Tajuddin et al. showed that patient who are on VA ECMO had a better renal recovery compared to VV ECMO, and he proposed that VA ECMO facilitated recovery by increasing oxygen delivery, decreasing hypoxia to the renal blood vessels. So from the simple concept of gross indication, general indications for any patient requiring renal replacement therapy to demand capacity concept, we are moving ahead with precision CRRT, so which includes multiple focus from the risk assessment to clinical diagnosis to indications, and you have to identify what is the target you want to achieve, then formalize a prescription, deliver, monitor the delivery, measure the adequacy, and then continuous monitoring is important in this patient to improve the outcome. So what there for the future? So always CRRT and ECMO, there are several opportunities arise that help improve the safety and efficacy of this CRRT, particularly when CRRT is also required with ECMO. And what is the optimal anticoagulation requirement for this? So there is no, is there any specific dose, standard dose or low dose or high dose? So the best strategy is not yet been clearly defined, and there is no probably criteria to monitor the efficacy as well of the anticoagulation in these patients. And again, data on pharmacokinetics and medication dosing in those patients with both CRRT. There are some dosing guidelines for CRRT is there, but when you combine together, I think there are no data, free data available for monitoring of drugs as well as pharmacokinetics in these patients. And we always have to validate and develop adequate defining criteria for AKI and identify the factors for survival and probably optimize the treatment. And probably finally the management strategies that ultimately prevent the occurrence of AKI. I think we have to focus on the prevention rather than treatment of AKI, because in addition to ECMO, another organ dysfunction, AKI going to increase the morbidity and mortality as well as increase the healthcare cost. Thank you.